Welcome to season 2, episode 12 of Dr. G at the Heart of Healthcare. We are fresh back from Vegas, and I have my guest, Reverend Brian Dunlop. Brian C. Dunlop. You got to say the whole thing. um, he was one of the faculty speakers with me at the City of Hope interdisciplinary end of life symposium. Many of you may have seen some of the pictures on social media, but we just had a wonderful time there getting to know each other. I'll do a brief bio on you, but I want to go ahead and let you say hi. Good morning.
Hey, good morning, everybody. I'm glad to be here. Glad to see you once again, Dr. G. Looking forward to the conversation.
Yeah, yeah. So, um, so anyway, we had a fantastic time. Chaplain Brian, what do you like to be called? What do folks call you?
Well, some of those things they call me is not appropriate for this podcast, but they call me Chaplain, Chap, Rev, Brian. That's what my mama named me, which is
That's what your
also
mama named
cool.
me.
But whatever
Okay.
you're comfortable with, Chap,
Uh,
Chaplain, Rev, I'm good.
all right, all right. So he's from Philly, in case you didn't hear that voice, hear his
So, so,
accent.
so technically now, I lived in Philly the past 2 decades, but when you're from New York, you're never not from New York. So
Okay,
I'm
New
from
York.
the Bronx, right? So that's where the accent really comes from.
Okay, okay,
Just
okay.
you
Okay, we
know,
know what's up. Don't mess with you. That's what I do know, being from the West Coast. Don't mess with you.
exactly. There you go.
All right. He's a husband and father, hospital chaplain, associate mentor at Enon Tabernacle Baptist Church, and a PhD student in palliative care with the University of Maryland, Baltimore. I don't know how you do all that, but we're going to dig into the things that you do today and also discuss some of our takeaways from the symposium. So I want to say it's Men's Month. June is Men's Month. Father's Day will be coming soon. So let's just start there. Men's Health Month. What do you want to say to the men, chap?
So, fellas, don't let the first time you meet your doctor be when you are appropriate for palliative care, meaning you have a life threatening or life altering illness. We've got to do better about having a primary care provider, about knowing your numbers so that you have a handle on your health. Um, because while Dr. G is a hospice provider, right, we don't want to get there too soon, right? We're all going to die someday, but we don't want to make that sooner than it has to be because we're not taking care of ourselves, and we just need to do more, do better.
Ooh, he went all the way there. Let's take a breath, everybody listening. This is for the fathers, the grandfathers. He went all the way there. And we're here for you. I mean, I will take care of you. I want you to come to hospice. But if you can do things preventative before, you can maybe delay that. All right. All right. He went there. He went there. So before we get into everything, I want to talk about the PhD program you're in palliative care. And first of all, people, palliative care, it's supportive care for people with serious illnesses that can be in conjunction with folks who have a serious illness while they're getting care and all that. It's not hospice. You can listen to another podcast to get deeper into that. But I want to talk about the PhD program. I was trying to clarify what PhD student versus PhD candidate. After you finish, you will be Dr. Dunlop. That doesn't mean he's Dr. G. Like, I'm a physician, I'm a doctor of medicine. But tell us how that program works, like for you being a student versus a candidate for PhD.
Right. So, with any PhD program, you have your classwork where you're going to classes like everybody else. The specific program I'm in is cohort based learning. So I'm in every class with the same folks. There's 10 individuals in my cohort, and it's an interdisciplinary program. So I'm in the classroom with physicians, with nurses, nurse practitioners, social workers, and one other chaplain. So it's really palliative care is an interdisciplinary practice because we're trying to treat people holistically. Taking care of their body, their mind, and their spirit. So it's really all that healthcare has to offer on a team, and specifically the difference between um, PhD student and PhD candidate. So I finished my classwork. Now I have to write my dissertation proposal. Then once my dissertation proposal is approved, once my research plan is approved, what I'm going to do in order to earn my PhD, then I technically become a candidate, right?
Okay.
And you have 7 years in which to um, get your research done and then defend your dissertation and become, in my case, it'll actually be Reverend Dr. Brian Dunlop, because I got to keep the Rev in front because
That's right.
that's according to where I've been called, right?
Yes. Yes.
So we're always going to be Reverend Doctor,
Yes.
and I'm gonna run around the hospital. I'm telling you, Dr. G, right now, I'm gonna run around the hospital. I'm gonna correct everybody, even the people that call me Brian. I'm be like, no, for the next 90 days, you're gonna call me Reverend Doctor, because after all this work, you're gonna acknowledge my title, okay?
Oh, that's
And
so funny.
they're gonna be sick of me.
Oh, that's so funny. That's so funny. You know what? Growing up in the Baptist church, I know about that. I grew up with Reverend Dr. E. Stafford. So I know about that because you say the whole thing, you say
Mhm.
all the initials, and you say the church is on the corner of 67th and Western. You got to
There
say
you
all
go.
that so everybody knows.
Amen. Amen.
That's your cultural competence lesson today, people. So there we go.
Mhm.
So let's go ahead and jump into the City of Hope interdisciplinary end of life symposium. We're going to talk about our takeaways, but I first want to drop some nuggets that I got from Reverend Brian Dunlop over here as we were in the sessions also. We were learning, we arrived on um what was it started on Wednesday with the pre-con web what was it, the workshop, and then 2 full days of learning, and we had a fantastic time there. And so in that environment with our other colleagues and the other disciplines, we're also able to learn from each other. In between sessions, we were able to network, we were able to just engage. And so this person here, just really dropped some stuff. And I asked him about the training of a chaplain, and I had to pull out my phone and write it down so that I could catch what he said, because I really wanted to talk about the role of a chaplain. I do hospice work, you all know, and so sometimes people say, "No, I don't need the chaplain. I have a pastor." Well, your pastor's not a chaplain, and no disrespect. Or I'm not religious, or people say things like that. So, what I wanted to just know as a physician is, what is the training like? What do they teach you in the program? And he said something to the effect of, it's about quieting your own inside voice so you can help others in their storm. And I was like, what? Come on, break it down a little bit. Not too much now because I haven't had my coffee.
So, well, I've had my coffee out here on the East Coast, but um, yeah, eh, our training really looks at being able to be with people where they are. And one of the requirements of someone considering entering chaplaincy is you have to recognize that it is, while the chaplain historically has been considered a religious figure, it is not a religious role. And what I mean by that is, yes, I'm a Bible toting Baptist preacher through and through. And what inspires me to help people is my relationship with the Lord Jesus Christ. Just got to put that out there. But I am here to help everyone of all faiths, of no faith. But in order to do that, you have to learn to put your stuff aside so that you can enter into someone else's story. Because if you're so caught up in your own agenda, you can't be of help to someone who's experiencing, their experience of illness might be the most difficult time in their life. And you're also not coming to fix anything, right?
Mm,
Like, quite frankly, Dr. G, you've been trained on how to fix things. A chaplain doesn't fix things. A chaplain tries to remind folks of those internal and external resources that they already have.
mm,
Because most people don't come to a stage in life where they're engaging the chaplain and they ain't never been through something.
mhm,
But in the midst of your storm, it's hard to see clearly what are the things that I have, that I've experienced, that I've learned in this life, and that I have to hold on to because we're so caught up in just trying to get through the day. So a chaplain comes alongside patients and helps reacquaint them, my language, no one else's, with what is sacred internally, and
mm,
then what socially in their family, their faith community, in their workplace, what do they have as far as to be able to provide, you know, the resources necessary to endure what they're going through. And
mhm.
so I don't come in as any type of savior, but if I can align myself with you and allow you to guide me to those resources that you already have, that you already know, then I can be of help. And yes, I'm also the person who comes when someone's nearing the end of life, and I perform those quote unquote priestly functions, right? Of praying, of scripture, and for some folks, they want to see that from the door, from the time I come in, right? And they want to know that I'm based in some belief, but it is not on me to cast my belief on others, right?
Mhm.
So the same way I can meet one of the senior sisters from my own church, right, is the same way I can come and meet someone who's agnostic,
Yes.
right?
Mhm.
And our training is geared to get to know ourselves, know our limitations, our growing edges, so to speak. Because if we're not aware of what's going on internally, then a lot of times what's going on internally can block my ability to serve someone else.
Wow. Now, people, I don't know if you noticed, I almost started rocking over here. That's that Baptist, you had me going because you just dropped it. So that was wonderful. Thank you for sharing that, and just thank you for your work because it's just I'm regurgitating science. You know what I mean? There's an art to medicine,
Mm-hmm.
and compassion and empathy and all that we have to have in end of life care. But to be what you have to be to people is it's a lot. It's heavy, and so I appreciate you. I love, my hospice team's chaplain and the team care that they give while we
Mm-hmm.
navigate the work that we do. So thank you for that. And so your topic was making a way out of no way, and you helped the audience understand how to serve the Black American or African American, however people identify, community in healthcare because we know about the disparities, we know about all this stuff, but how to handle them. And I just have one quote from your talk, and I'll let you elaborate on your talk. Um, it said that you said that discomfort is an invitation to curiosity. And the other part I give two, that we have been believing in miracles to get through life in this society. So let's talk about that.
Yeah. So one of the things that I've learned in doing this work is first for our community writ large. Pew Research did a study. 97% of folks who identify as African American believe in God or a higher power that is intimately involved in our lives. And we know, and I'm sure you've educated some of your listeners on the fact that there are healthcare disparities. Well, there are disparities that yet remain in our society, and they have a historical basis. And so that what we go through outside of healthcare informs how we navigate when we need healthcare, right? Those social determinants of health don't just get dropped off at the hospital doors. And a lot of African American faith, that belief in a God that's intimately involved in our lives, is how we've been able to endure racism, systemic racism, how we've been able to navigate our lives. It's been a primary resource. But when we come into the hospital examination room or in our patient room, and we, a lot of times, when we start to speak of our faith, our belief in miracles, that can cut off communication for someone who's not comfortable with expressions of faith, right? Who's not aware of how our faith informs our life, how it is a primary resource. So when someone is now challenged with some of the most difficult circumstances in their life, to have the expectation that they're solely going to be dependent upon science when science has not gotten them through, is there's a disconnect. And so really it's about understanding that when someone says, well, I'm going to leave it all in the Lord's hands, that does not mean, doctor or nurse or psychiatrist, that there's not an expectation that you are part of that solution, right? So my hope on a miracle, well, you might be an instrument of that miracle making, right? That God may use you. So it doesn't remove you from the equation. In fact, if I share my intimate beliefs with you, that's an opportunity for you to come closer, for you to explore what's most important for me in my life, right?
Mm-hmm.
And how we can both work together, me on the faith track, you on the medical track, to try to alleviate my pain, try to heal my body, or try in many respects to decrease the amount of symptoms I'm experiencing and allow me to live as long as I can with dignity.
Mm.
And but if you are taken back or put off by me talking about miracles or me talking about how God is in control, well then I'm no longer going to receive the care that I'm quite frankly entitled to because you took two steps back,
Wow.
you know. Um, and when it comes to serious illness, the fact remains that many of us suffer from um, uh, different conditions. I myself, I'm not ashamed. I suffer from hypertension. My mother suffered from hypertension. My daddy suffers from hypertension, and he's 92. So I know I can live with it because I monitor it and I take my medication as prescribed. And so, but I also pray about my blood pressure too, right?
And that's all right.
Um, but that doesn't mean that I don't take and I can't even pronounce it. I was going to get slick, but I can't pronounce the
Don't get
name of
slick.
my medication, right? I'm not going to even try because I'll just get all twisted up. But I take my medication every day.
Mm-hmm.
I pray every day.
Mm-hmm.
Those two are not in conflict.
Yes, I like that.
you know and so really that's what I'm trying to convey within the healthcare system is you need to draw closer and be curious about what our wishes are, what our desires are individually in that one-on-one encounter, and not dismiss us, which or fail to introduce other pathways because you anticipate, based on hearing our God talk or statements, declarations of faith, that it is not going to be effective. Because that increases the healthcare disparities that we experience. And you know, Dr. G, when folks are seriously ill, the last thing we need is a healthcare provider thinking that, well, I can't introduce A to them because they're not going to be accepting of it. Well, A might
Mm.
have been that sweet solution, right?
Mm.
Um, and yeah, so that's where I'm at with it, and I'm committed to also educating our community that, yeah, get down on your knees and pray for healing, but take your medicine too, right? Go get your checkup,
Yes.
because it's both and. It's not
Yes.
either or,
Yes.
right?
Yes.
You know, and I think about, I'm not going to tell the whole long joke, but I think about the man who's, you know, uh, goes out fishing and gets lost at sea, and he starts praying for the Lord for rescue, and the boat comes by and he goes, no, I'm waiting on the Lord. And then the helicopter comes, I'm waiting on the Lord. Well, then when he gets up into those pearly gates, and God says, what are you doing here? I didn't expect you. He's like, well, I was waiting on you. Well, no, I sent you science. I sent you doctors who go through a whole lot of training to
Mhm.
be able to help heal you. Um, and meanwhile, you thinking there's just power in prayer? Yes, power in prayer is getting that appointment.
Yes.
And also, you know, the work that you specialize in allowing folks to have, you know, the palliative care phrase is goal concordant care,
Yes.
right? And this is the thing I try to tell providers, as well as potential patients, is that goal concordant care means that we are in alignment, that you understand what it is I'm looking for, what I'm hoping for, what I'm praying for. And then you take that information and, based on your education, you try to meet that need.
Yes.
And then I can live until I die. Because we all gonna die someday. But I ain't in a rush to get there, right? You know, I want to hear that, well done, my faithful servant. But I don't want to hear it tomorrow,
Right.
right? And
We got
certainly
stuff to
not because
do.
I ain't taking my medication.
No, not
No.
for nothing, not for nothing like that. We want to live until we die. All we do, and that's what our role is in hospice and palliative care, to find out what matters to you. We
Mm-hmm.
just celebrated. We'll observe what matters to you day with the conversation project. Our job is to find that out and have that goal concordant care. So each discipline does it. As a physician, I want to know, okay, you've been through this journey with your COPD, your cancer, the heart failure, all the stuff you've been through. Now, what are we doing? How are we, going to take care of you at home? And are you trying to make it to this wedding? Are you trying to wait for your grandkid to be born? What
Mm-hmm.
is it? And so that's what we do. And so I really, even though I do this work, the way that you verbalized it really helped enlighten me a little bit more. Um, because again, like you said, it's about putting your stuff aside as the chaplain so you can help the person in their storm. And you just broke it all down. So I don't have to say nothing on that. So your talk was great. And so I hope people have a better heart understanding of how to navigate healthcare of Black Americans. I did a talk on it a couple years ago, and I really helped them to understand the diversity in the community. Like, we can't even all be in a box, even though you and I may be vibing on this Baptist thing and all that stuff. You're on the East Coast, I'm on the West Coast. Again, there's variation in between. Some people are mixed with Caribbean, African, all this stuff. Again, it's all kind of stuff. And so you got to put your stuff aside and meet people. And the person declaring their faith is not for you to say, oops, well, I'm not doing my job. And not that anyone does that, but don't have that, check that unconscious bias that, oh, they're believing for a miracle. That means I shouldn't put in the consult for the transplant, because maybe that is what they want. So that was so good. That was so good. Thank you, sir. So my talk was about, what do you guess? Communication and normalizing hospice care in the United States,
Hmm.
right? Because again, when you do get to that point, you should know when it's time. Your doctor should tell you when it's time before the last 2 days of your life, because the benefit is 6 months. But we've talked about that a ton here. You guys know about my book, The Real Deal About Hospice, but that's what I talked about. And so let's just jump into some of our takeaways from that. I have my notes here. So we kicked it off on that Wednesday. And first, let's give a shout out to Dr. Benagerie,
Hmm.
the brains behind this. Um, Thank you for creating this, leading this conference, the symposium for the community so people can learn and engage and we can move the needle forward. That's what I hope happened. Wait,
Hmm.
you have any words for her?
So she is, full disclosure, she's a member of my PhD program, cohort. She's a cohort member, so I've been in class with her for the last 2 years. She's amazing. She's passionate about what she does. So she's not only a physician, but she's a physician educator, educating other physicians, and just a dynamic lady. So I'm very grateful for the invitation, to attend the symposium, and look forward to, continuing to further the work, right? Because this right now we are at a really tipping point where palliative care writ large, and hospice is along the continuum of palliative care, right? Because a lot of times those serious life altering, life threatening illnesses do end up in folks dying. That's the reality, right? So we are all in one continuum. But the fact is that we have an aging population, and we have more and more folks coming in with multiple illnesses, and making sure that we have physicians like yourself, Dr. G, who are adequately trained to deal with their symptoms, to deal with the emotional heft of caring for a dying patient and their families, because in many instances, the families are part of what we consider a caregiving unit,
Hmm.
and they're part of our responsibility too. But, hospice is what, 50 years old? Palliative care is, really grow in this country, grew out of the hospice movement.
Yes.
So while, there a lot of the other specializations in healthcare have been around for as long as there have been doctors, we're relatively a new field of study,
Hmm.
right? And I think it's wonderful because you're able to take care of people so that there's not this just terrible suffering,
Hmm.
right?
Hmm.
So that they can die with dignity, right? And fulfill some of their last wishes and have that opportunity. And so what she does, what you do, is incredibly important, because there was a time where when folks were dying from cancer, they were in big wards, in pain that was not being taken care of, and dying horrible deaths. And because of providers like yourself and Dr. Banerjee, that no longer has to be the case.
Hmm.
And for that, I'm very grateful.
Yeah, yeah. I don't remember who that was with us, but they talked about their parent went through that, and that's what got them into the field. But I can't imagine that. So yeah, let's keep moving that needle forward. So we started with that workshop, supportive oncology, early integration of palliative care. Right, we want to put in a palliative care consult when you get the diagnosis. We're not in competition. Let's
Mm-hmm.
not wait until you finish all of your experimental treatments and all that stuff, and then they're calling the back line at the hospice to barely get you home. That's not it. And that's the message you should take from that. So I don't know if you want to say anything about that, but we can move on to Thursday takeaways.
I'm following you.
Yes, sir. Yes, sir. So Thursday, let's see, we had that keynote. We talked about some psychedelics. That's really moving forward for therapy. Ooh, this one. The death of a child and humanities and cultural perspective. That really, I didn't even have to look at that, but that was the thing that really just, whew, like blew me away. I was sitting in the back of the room and I had to like take deep breaths to get through it.
Mm-hmm.
So there was a mother who lost her 30-year-old son the day after Thanksgiving 2022, and he was a community activist in Oakland. He had a severe asthma attack and he died. And so they shared the story in photos because they had a family friend who was a photographer, and she took photos at the end and what was happening in the family. And hearing a mother's pain for me all the time as a mother, that's hard. I've been at a lot of bedsides, and someone recently said to me at a visit, um, she said to me, and this relates to that, she said, there is no word in the English language to describe a parent losing a child. And I was like, that just happened to me this week. So anyway, that was what impressed me. And what I want to say about it, connecting it to your talk from there, is the very same hospital she was at that I will not name here. Um, they had that great story. They talked about how the staff was so accommodating, how, they got the corner room, everyone was able to flow in and all that stuff. Well, guess the other side of that coin. I have a black family that also had a situation, end of life, at that same hospital. And while they were experiencing emotions or whatever, security was called.
Yeah.
And that is a failure of the healthcare system, of the human beings there, uh, cultural incompetence at the highest level. And that, again, relates to what you said. And so I just, even thinking about it, just, it like cuts me. What do you want to say about that, Chaplain?
So there was a study out of Chicago, actually led by a chaplain resident, and that's part of our training. We do a year-long residency in hospitals because he saw the disparate response to families' expressions of grief in the hospital based along racial lines. So this is
Mm,
something that um, has been researched. There are more and more people working on it, but it doesn't solve the problem. It does bring light to the problem. And I myself try to respond when there are security calls, because I go in order to try to de escalate circumstances. And a lot of times, we mistake expressions of grief as threatening behaviors because we are uncomfortable with the folks who are expressing them, right? And if we're uncomfortable with the folks who are expressing them, that's immediately puts them along a different trajectory where now, instead of us being supportive, we become adversarial. And that's a reality, right? And that study was done in Chicago, but it could have been done in my hospital right here in Philadelphia, where you'll have one group of people will have family fighting between themselves. That's natural, that's common, that's not unusual. And arguing, and the description will be, oh, they're just very passionate and they love their loved ones so much. Then you'll have another family, and it'll be, oh, they're just hostile, and we got to make sure that they don't get out of control. Same behavior, different interpretation. I mean,
Yeah.
this is the reality of living in these yet to be United States.
Yeah.
And there's, that's just real.
Mm-hmm.
And part of the reason why, when I came into chaplaincy, a lot of my work is around advocating for communities of color, is because I've witnessed the disparate treatment by folks who are well intentioned.
Yeah.
These are not evil people. You don't go into healthcare
No.
because you don't love and care for people, full stop, right? But we still have internalized biases that, some respect, your biases keep you alive, right? But these unconscious biases can also be life limiting on other folks. And, I won't go much further on that.
Let's go.
You're all they're gonna be like, he ain't the chaplain, he's the revolutionary, power to the people. Yes,
We
but
can, but we're not. We're
yeah,
not.
we're not.
We're just
We're not.
trying to unite. We're trying to bring unity and
Yes, we are.
harmony. Um and so we're here. So anyway, that was my takeaway from Thursday. Um I don't know if you have one particular one from that day that stood out to you, but that was like my main one that was a huge had a huge impression on me outside of all the folks we met, having my first dirty martini and all the other things in between, the great
You went
food,
there. You
the
went there.
fun, yeah, and all that stuff. So what were you have a takeaway you want to share
So,
before we wrap this up?
so specifically to my takeaway overall, what was energizing, what was inspiring, was that we had people from all over the world, right? Literally from as far away as Mozambique, right? And was the woman, I think, from Serbia who presented, um, who are dedicating their lives to trying to provide the absolute best care for people who are nearing the end of their lives. And that was inspiring. Folks ask me, well, wouldn't that be depressing going to something stunning? No, because there is so much love still yet in this world, where people are taking all of their training, their knowledge of science, their passion, their compassion, and they're committed to creating safe spaces in which individuals and families can be honored and can experience a good death, whatever that means to them. And then, in specifically the case of that woman who shared the story of her son's death, she's taking her grief and teaching others and sharing her experience so that people who are working in this space can learn more, can become better at what they do. And that's inspiring, because there are some really brilliant people there, and coming from all different perspectives. And yet we're all have one common goal, and that is to, my language, love on people as they or their loved ones leave this earth.
Mm.
And to me, that's just wonderful.
Ah, that's fantastic. Yeah, the symposium was fantastic. We had everyone in the whole continuum of the end of life, even first responders. I love the EMT and firefighter and LAPD
Hmm.
panel. That's where I'm from, and so they try to say NYPD's it. No, LAPD. East Coast, West Coast rules.
Yes,
Anyway,
indeed.
Yeah. And so, we just touched on all the stuff, even organ donation, all the things that are along the spectrum of care. And they said they're going to be bringing it back to Cali next year, so that would be great. You gotta come back, and I'll show y'all around.
So I look forward to it, and I'm looking forward to, hopefully you can live stream your podcast from the symposium. Now that would be hot.
I
I'm
can
just
put this
saying.
I can put this microphone in my suitcase. Let's do it.
Just what you don't have to travel that far. It's gonna be what in Duarte.
Hey, let's
So
do it. Let's
look,
let's let's
I'm
turn let's turn it on, and maybe I'll make the dirty martinis live.
well now. Brian might be down with that, but Reverend Dunlop has to say that might not be the appropriate venue.
Nah,
But
nah,
I'm
nah.
just saying,
You get a virgin one.
yeah, okay, okay.
You just get
We,
the olive juice.
oh, gee, thanks. At
Not for
least
your
I
blood
won't get
pressure. Never mind.
dehydrated, right?
No, no, not for the blood pressure. Never mind.
Yeah, yeah.
So, no, it has been so good to talk to you, and I look forward to further collaborations. You have dropped so many gems today for Men's Health Month. Spirit, you've touched everyone's spirit here, and that's what it's about. Whatever belief system you have, agnostic. I remember from Endwell last year, there was a chaplain who's atheist who shared a story, and I was like, wow, you're a human. You touch people with the resources they have inside and remind them of that sacredness. And someone else would call that coming home to yourself. So
Hmm.
I love that. I love that. Shout out
Not
to
you
Dr.
dropping a
Tama.
word.
That's Dr. Tama. I can't take credit for that.
All right.
Dr.
Well,
Tama. Anyway,
so
so
have you
great.
said it before? I'm gonna teach you something now. Have you said that before? Have you quoted Dr. Tamar with that?
Yeah, yeah, she has a book.
Okay, so
Homecoming.
all right, so this is the thing. The first time you say it, you give her credit. The second time, this is Baptist preacher rules. The second time you say it, you say, as I have heard. And then the third time you say it is, as I've always said, right? So you get that attribution the first time. After that, you start to assume ownership.
Lord have mercy. I am not that profound. I gotta lift her up. And I'm gonna send you the link to her social media and her book. And I also want to get a link to that article you mentioned about the difference in the response to grief
Hmm.
from various cultures. That's important because I have a friend, um white woman. She told me when her brothers, were in the hospital, her brother threw a chair. I was like, oh, whoa, in the hospital. Okay. So anyway, we learned today, and we're gonna be better. We're gonna do better because we were together. So thank you, Reverend Brian C. Dunlop, for joining me on the show.
Thank you so much, Dr. G. I appreciate you.
All right, everyone. Peace. Men's Health Month.
Know your numbers.